Good evening, everybody. My name is Mike Gallagher, and on behalf of the Planning Committee for the Michigan American College of Cardiology Education Work Group, I'd like to welcome you to our first of a series of virtual webinars that we're going to conduct on the second Wednesday at 6 p.m. It's entitled Second Wednesday at 6, and I'd like to thank the entire planning committee outlined on the left, a wonderful group of physicians and staff throughout the state of Michigan that have helped design this webinar series. You can see here in the middle that we plan to have monthly either grand rounds formats or case-based educational presentations at the dates outlined on the PowerPoint slide. Now, the goal of this is to encourage statewide education and participation to really get different centers and hospitals and cardiology divisions and training programs to really collaborate with education as well as to build some relationships. We plan to have host sites as well as moderator sites, and we'd really like to have a focus on fellows in training, and they'll be involved in each of these web-based seminars. Now, if you go to the Michigan ACC website, you'll see that if you go to the home page, you can sign up for the second Wednesday at 6, shown here. This is today's first session is entitled The Evolving Role of Cardiac CTA and FFRCT in the Assessment of Coronary Disease. And for this session, we'd really like to thank HeartFlow for their generous sponsorship of this event. HeartFlow has been an invaluable member of the team to help centers throughout the state of Michigan start up their FFRCT programs, and they've been uniquely helpful here at Beaumont, and we're grateful for their support and expertise. Now, some housekeeping issues in the Zoom format. You can use the Q&A box to enter some questions, and we'll have a moderated discussion for the final 15 minutes of the educational event tonight. Now, the talk today is on the evolving role of cardiac CTA and FFRCT in the assessment of coronary disease. We'll start off with evaluating stable coronary disease. Myself and one of our cardiology fellows, Travis Tagami, will move forward to the acute chest pain arena with Dr. Kavitha Shanayan and Dr. Palomo. And then we'll move onward to interventional perspective, and Dr. Safian and Dr. Rusia from Beaumont will provide that session. We'll then have a moderated discussion with Spectrum Health. And I'd like to thank the faculty moderators from Spectrum, David Langholtz, the head of cardiovascular imaging, Dr. Ryan Mader, the head of interventional cardiology and the director of the cath lab, and Mike Vredenberg, the director of cardiac CT. Really grateful for their help in planning the session and their involvement here tonight. We also have 3 cardiology fellows. Travis Tagami will present case number 1. Andy Palomo will present case number 2, and Akash Rusia will present case number 3 for this evening's session. So before we start, I'm going to share a video with you. Part of what we'd like to do in this series is really give everybody a flavor of different institutions. This is a window into Beaumont Health. So with that, I'd like to introduce our first case presenter. Travis Tagami is one of our outstanding fellows here at Beaumont Royal Oak, and he's going to present a case to lead off the talk of the role of cardiac CTA and FFRCT in the evaluation of stable coronary disease.
All right, thanks, Dr. Gallagher. So I'll get started with the case here. So we have a 71-year-old female without a prior cardiac history. She presented to the Beaumont Emergency Center with 3 days of chest pain. She had a negative EKG and a negative troponin. She underwent a stress MPI. She exercised for 8 minutes, underwent 10 METs, and achieved a 90% peak maximum heart rate. Here's her baseline ECG. Here's her ECG during stress. You see 1 millimeter of upsloping ST depression in the inferior and lateral leads. Here are the MPI images showing no defect. So she was sent home from the emergency center with instructions to follow up with the cardiologist the next day. She continued to have some intermittent chest pain when she was evaluated in the ER, a pretty common clinical scenario, and which we see in practice all the time, and the clinical cardiologist decided to order a CTA. So the picture on your left is a 3D reconstructed image showing the heart in an AP projection. Next, we see a maximum intensity projection image, or MIP, of the LAD in an LAO view. It shows a 50 to 70% non-calcified eccentric plaque in the mid-LAD. So if we do a 360-degree rotation around this area of interest, we can see the plaque. We highlighted it here with the just color from the slide. Next, we see a cross-sectional image using something called the G tool to look at the pre-lesion, circled in yellow, intra-lesion, it's circled in yellow. See the cross-section with the yellow line, and then post-lesion. So finally, we take that data set and create a physiologic flow map called FFRCT. It allows us to pinpoint FFR values anywhere along each vessel. With this image in particular showing a positive FFR of less than 0.8 in the mid-LAD, which was confirmed here with invasive angiography. This area was stented and the patient's symptoms resolved. Turn it back to Dr. Gallagher.
Thanks, Travis. So that was a really great presentation and a great case to highlight some of the really important aspects of what I'd like to share with you tonight on this presentation entitled The Role of Cardiac CT and FFRCT in the Evaluation of Stable Coronary Disease. So I am a consultant and mentor for HeartFlow, this is my disclosure, and help sites across the country start off their FFRCT program. So here tonight to talk about imaging and coronary artery disease. And we're really going to focus on anatomic-based techniques such as coronary CT angiography. This beautiful volume rendered image on the left outlines coronary anatomy nicely on a CT angiogram. And we're all familiar with physiologic functional techniques that are based upon echocardiography and nuclear-based imaging. This is part of what we do every day as we care for our patients. What I'd like to share with you today is that if you combine both a CT anatomic technique together with a physiologic flow map that is derived from those CT images to create a physiologic map of the degree of anatomic stenosis, this is the combination of both CTA and FFRCT, and we'll discuss how we use that throughout the rest of the evening. Now, the reason I think this is important is that I really think that we're in the midst of moving towards a CT-first strategy in a growing subset of patients that we care for in cardiovascular medicine. The European guidelines, 2020 guidelines, have raised CTA to a class 1A indication in the evaluation of patients with chest pain and suspected coronary disease. And the National Health Service for the United Kingdom guidelines also adopted a CT-first strategy nearly 3 years ago. And there's growing momentum in the United States to do the same. A summit was convened by the American College of Cardiology at the Hart House in Washington, D.C., and they reviewed the current evidence and recommendations for coronary CTA as a first-line strategy in the evaluation of stable coronary disease. And they really focused on the need and the pathway to enable prioritization of CT angiography. And they highlighted some important steps that revolved around reimbursement and access. But one of the important features was emphasizing education for coronary CTA to bring this more into the awareness of fellowship programs and educational events. And it's part of the reason why we're here tonight. So I'd like to use this illustration as we sort of introduce the concept of imaging and accuracy. Imagine for a minute that we're looking at, we all are evaluating 100 patients this week, either in our observation unit or in our office. And of those 100 patients with chest pain, 10 of them have severe blockages as the cause of their chest pain. We know that the current stress imaging techniques based upon echocardiography and nuclear medicine have a modest sensitivity. They'll detect about 7 or perhaps 8 out of 10 patients with an abnormal stress test of patients that have severe coronary artery disease. We also know, so there's significant false negatives, so 30% or 25% false negatives shown here. We also know that these stress imaging techniques really come with it a significant number of false positives, abnormal stress tests in patients with non-cardiac basis for their chest pain. We all see this throughout our daily practice. And these false positives have consequences. They often lead to unnecessary catheterizations. They can expose your patient to excess radiation and potential procedural risks, and they really do have an impact on your hospital efficiency. So we'll now shift our attention to coronary CT angiography. It is really the only non-invasive imaging method to evaluate the primary disease process, or atherosclerosis. Coronary CTA provides definitive assessment for the presence versus absence of coronary disease, as shown beautifully by these cases below. If we shift to our model once again, of those 10 patients with severe coronary disease, coronary CT angiography has an excellent sensitivity, detects at least 90% of these patients with severe coronary artery disease. Few false negatives are noted. Now, coronary CT angiography, however, also has the same problem as stress imaging, and there are frequent false positives. And what I mean by false positives in this domain is overcalling the degree of stenosis. This is an example of a patient with a right coronary artery lesion that was called as a 50 to 70% stenosis. This patient went to the cath lab and was found to just have mild coronary disease in the right coronary artery. So this heart catheterization was potentially unnecessary. Now, if you can take all of these false positives, these abnormal boxes on the gray circles, and you can remove the majority of those false positives, that's what FFRCT does when you add it to coronary CTA. It allows you to send that CT data set on for a non-invasive flow assessment to look at the functional degree of stenosis. And in this particular case that we did as part of a research endeavor, this patient's FFRCT of the right coronary artery was normal with no suggestion of flow limitation, and the patient therefore would not have undergone a heart catheterization had we used this technique prospectively. So this patient could have been avoided a heart catheterization. And this is possible because CT angiography is excellent with anatomy. It maintains a sensitivity, but the addition of FFRCT reduces those false positives, improves the specificity, and it really does address the Achilles heel of cardiac CTA, which is intermediate stenosis and calcification. So we are all quite familiar with how invasive FFR helps us in the assessment of our patients with anatomic disease on an invasive coronary angiogram. And we know that invasive FFR better informs our decisions on when to proceed with PCI. There's great data to support that we're all familiar with the FAME trials and many others. What I'd like to share with you tonight is that coronary CT angiography has its own similar, a surrogate for invasive FFR, or FFRCT, which has been shown to accurately correlate with invasive FFR. And it really allows us to look at our patient's coronary anatomy and blood flow with a single non-invasive imaging test. Indeed, it provides hybrid imaging. So what is FFRCT? So FFRCT is a non-invasive CT-based assessment of fractional flow reserve. So if you look at this patient in the bottom left who has an LAD stenosis with significant calcified plaque, it was uncertain the degree of stenosis. So we sent this data off to HeartFlow, and with no additional imaging, no administration of medications from the typically acquired coronary CTA with this FDA-approved model, we were able to create this flow map that correlated with the anatomy, and we were able to determine this patient had a severe stenosis. The patient went to the cath lab, and as you can see here, had a severe lesion in the left anterior descending. The invasive FFR correlated very nicely with the FFRCT, and this patient underwent PCI. Now, there's many, over 300 publications that have focused on FFRCT, and many of which over 5 and 6 years ago really established the accuracy of FFRCT, that it correlates very well with invasive FFR. So how do we use this combination of CT and FFRCT here in our hospital? We image over 5,000 patients with CT angiography per year here at Royal Oak Beaumont. And what we tend to do is if our patient has chest pain and they have a less than 25% diameter stenosis, these patients tend to be treated medically if it's normal or less than 25% stenosis. If our patients, in particular those with concerning features, proximal stenosis, if they have a greater than 70% stenosis, the majority of these patients will undergo invasive coronary angiography with or without invasive FFR. But it's this group in the middle, predominantly all the 50 to 70% stenoses, and a subset of the 25 to 50% stenoses that we send off for this non-invasive flow assessment, this FFRCT, to give us a physiologic flow map and to assign an FFRCT value together with the anatomy. And it's important that we actually correlate the anatomy together with the FFR values. We look at, are we looking distal to the stenosis versus terminal vessel? There's lots of nuances that we'll talk about tonight, but it's important that you all realize that this is a continuum of risk. Very much like in the invasive FFR world, we know that the lower the invasive FFR, the higher the subsequent event rate. The same holds true for FFRCT. It's been shown nicely in several trials, including the NXT database and the advanced registry, looking at well over a few thousand patients with FFRCT. For every decrease in FFRCT values, there is a relative increase in the overall cardiovascular event rate in MACE. And so if we go back to our case presentation, we suspected this patient had a false negative, ongoing chest pain, normal stress test. The patient was therefore sent for a CTA, and the CTA demonstrated a 50 to 70% stenosis. When you have intermediate stenosis, it's an ideal situation for the role of FFRCT. You can see the flow map shown here in the bottom left. It correlated nicely with the invasive angiogram, and indeed it's been shown to correlate, invasive angiography has been shown to correlate nicely with FFRCT, and you'll hear much more about that by Dr. Safian this evening. So in summary, coronary CT angiography is an alternative to stress testing among low to intermediate risk patients with chest pain. It has an excellent sensitivity, and its FFRCT is a non-invasive technique that provides an accurate assessment for defining lesion-specific ischemia that correlates well with invasive FFR, and it allows us to improve the specificity of a combined CT and FFR-based imaging strategy. So with that, I think I'll conclude here and turn it over to Dr. Langholtz and Vredenberg for a quick question as we transition to the next talk.
That's great, Mike. Thank you. For all the participants, please use the Q&A. If you could just type a question there. If you have it, we'll pose it and look at it to respond. Mike, given that the ACC and European Society of Cardiology both endorse CT, first for consideration, what are the patients you think probably aren't best for coronary CT?
Yeah, that's a good question, Mike. I think that in general, the FFRCT has not been shown to be, not been proven to be beneficial or accurate in patients with coronary artery stents. Now that is changing, and there's some indications where you can use it with patients with stents, but in general, if a patient has a stent, I wouldn't do a CTA or FFRCT. In patients with prior bypass graft surgery, I think CT angiography is probably not the first technique to use. We typically would use a functional imaging technique in that situation. Now, there's some situations where you want to look at graft patency. In situations where patients have abnormal kidney function, just like any other CT-based strategy, if patients have chronic kidney disease, you tend to shy away from a coronary CTA. In patients where you can't control the heart rate, someone who's got atrial fibrillation or a rapid rate that you cannot bring down into a target goal range of less than 60, less than 65, those patients probably should not undergo a coronary CT angiogram, and also those, of course, with contrast allergies. There are other unique issues in patients with high BMIs, et cetera, but what we've found is that in certain patients with faster heart rates or abnormal heart rhythms or elevated BMIs, with proper technology and expertise, we can start to image some of those patients. But in general, the big categories I think would be stents, bypass, kidneys, allergic reaction, fast heart rates. I think that probably closes out the list.
That's great. All right, our next speaker is Dr. Kavitha Chennaiyan. She's going to talk to us about CT-FFR in the emergency room. Thanks, Kavitha.
And I'm going to jump in for 1 second. Before Kavitha speaks, I've got Dr. Andy Paloma with me, who's going to kick off her presentation.
Hi, everyone. Thank you for joining today. I got a good case to highlight here the use of CT-FFR in the emergency department prior to Dr. Chennaiyan's talk. So we have a 50-year-old woman coming in with intermittent exertional chest discomfort ongoing for several days, and she presented to the emergency department for that. She has a history of diabetes, hypertension, hyperlipidemia. Here's her presenting EKG with no acute ischemic changes, and her initial troponin was negative in the emergency department. We opted for a non-invasive strategy and went for a CTA coronary angiogram as her first test. So here's her right coronary artery. Here you see either a soft non-calcified plaque versus a misalignment artifact, and that can be seen here in two views. And here you have the LAD showing a moderate 50 to 70% stenosis. Due to the inconclusivity of the study, we did opt to send this to HeartFlow for FFR. And the FFR in the right coronary artery was grossly positive. You can see a drop off of 0.98 to 0.57. So that's suggesting that it was a severe stenosis, and subsequently she was referred for invasive angiography. And here you can see her mid-right coronary artery with a severe 95% stenosis, and she subsequently went for PCI, the RCA. But what about the LAD? Here you have the LAD, and that was also went for FFR. When they go for FFR, they get all three vessels, and here you see a drop-off of 0.96 to 0.75, so that was positive for CT-FFR. And here is her invasive coronary angiogram of her LAD, showing what they call a 65% proximal LAD stenosis, and subsequently did go for invasive FFR, which ultimately was positive at 0.71. So she did end up going for PCI of the LAD and did well. So this is a good example of a new onset chest pain patient going for CT-FFR with a 2-vessel PCI. So with that, I'd like to go on to Dr. Shanayan's talk for CTA in the emergency department. Thank you.
I think you're on mute, Kavitha.
Sorry about that. Hi, everybody. And thank you so much for all the organizers to invite me here. It's wonderful to be here for this important initiative. So these are my disclosures, which are similar to Mike's. So before we begin, we should actually kind of scope out the problem. Why are we even talking about this topic? And that brings us to the very important issue of acute chest pain, and in the US alone, there are about 8 million chest pain visits to the ER per year. And this number has been pretty steady in the last few years. And missed MI rate among these patients is anywhere between 4 to 13%. And this leads to mortality rates of 10 to 25% among these patients. And this actually also translates to a very large proportion of the ER malpractice dollars, which is about 20%. So you can see that the issue of acute chest pain is actually quite big. Now, with regard to the key to acute chest pain evaluation, it is all about cost-effective triage. And here we are defining cost-effective triage as efficient early testing with high diagnostic accuracy. So what does that mean? So that when we say high accurate diagnostic accuracy, we are talking about a low miss rate for acute coronary syndrome. And by consensus, we decide that that's less than 5%. Now, with regard to CT angiography, coronary CT angiography in acute chest pain, it is no longer speculative. This is actually now in widespread practice. It's in prime time, actually. So there are 3 main trials that actually helped put CT in this prime time in this area of acute chest pain. The first multi-center trial was CT STAT, which we led from Beaumont back in 2011, where patients were randomized to either CT first or to myocardial perfusion imaging. And then very rapidly, this study was followed by Akron PA study and the ROMICAT 2 study, both of them also multi-center trials. But in this case, it was CTA versus standard of care. And all of these studies, these 3 studies put together, showed that there was actually CT was much more effective in the emergency department with regard to length of stay and misdiagnosis, as well as cost of testing. So what we do know now is that CTA in the emergency department can be performed rapidly. It does lead to decreased length of stay, increased expedited discharge. It is accurate, as Mike was talking about. It has very, very high sensitivity and very, very high negative predictive value. And so anytime you have a test that has high sensitivity and high negative predictive value, it's a great test to rule out something. It's the same thing with the high sensitivity troponin, for instance. CTA has plaque characterization capabilities, which really ups the ante. It is cost effective and it has long-term favorable prognostic data as well. Anytime you have high sensitivity, that comes at a price, and that has to do with decreased positive predictive value. In this meta-analysis that looked at all those 3 studies, as well as the first study that we did at Beaumont, which was a single center study, and this meta-analysis looked at these 4 studies put together, and you could see that actually the revascularization rate and the invasive coronary angiography rate was much higher in those patients receiving coronary CT angiography, and that's because of this issue of the low positive predictive value. And that is 40 to 50%. So the biggest challenges for CTA in the emergency department is adjudicating stenosis in the intermediate range that Mike was showing us. And the decision-making with respect to the presence of extensive calcification, which tells us that it's really impossible to see what's happening in the lumen beyond the calcification. So again, here the question is, can we adjudicate this without an additional test? Because in the past, these patients would either get an additional test, such as a stress test, or they would have been sent to the cath lab. So FFRCT in the emergency department can potentially answer the question. So in our hospital at Royal Oak Beaumont, our program was initiated in August 2015 with FFRCT. We have performed nearly 2,500 FFRCT cases, of which nearly 40% are from the ER. And of all the cases that we do, nearly 15% of our CTAs are sent for FFRCT. And now it is actually widely requested by interventional cardiologists, emergency department physicians, as well as internists, as the familiarity with this technique increases. We published a study earlier in 2020, looking at 3-month outcome data in patients coming in with chest pain to the emergency department. And we compared those patients that had CT alone versus those that had CT and FFRCT. The most important thing that I want to point out your attention to is that there was no difference in major adverse cardiac events between CT and FFRCT. But look at the difference between FFR negative and FFR positive. So huge difference with regard to MACE, with regard to cumulative costs, as well as non-obstructive disease on CT, which is actually a big deal. So when you look at FFRCT negative versus positive, patients who do have a positive FFRCT actually are unlikely, very highly unlikely, to have non-obstructive disease on invasive coronary angiography. Importantly, with this approach, the positive predictive value increases from 40 to 50% to 80 to 85%. But there are some issues with regard to adopting FFRCT in acute chest pain. So feasibility is a challenge. Patient selection is a challenge because we do have to pay attention to artifacts and stents and bypass grafts and so on. Interpretation, as Mike was alluding to, is nuanced. It's not merely a number that we are looking at, as well as the complexity of the workflow in the ER. How do we send this? Who sends it? Who's reading? And when does it come back? And how is it reported? And so on. So there are still some unanswered questions with regard to FFRCT, such as longer-term outcomes, usefulness in non-STEMI and high-risk patients, cost effectiveness, and also mandated clinical decision-making, And as in, there is no study to say that if you have an FFR that is greater than 0.8, then this patient should not go to the cath lab. There is no such study yet. Comparative effectiveness versus of this approach versus standard of care approach in the ER. So those are all the nuances. And in summary, CTA in low to intermediate risk acute chest pain patients is extremely useful for diagnosis and prognosis. And FFRCT can improve specificity and adjudication of uncertain coronary stenosis as well as their functional significance. However, the workflow is challenging, interpretation is nuanced, and as always, more data are needed. Thank you so much for your attention.
This is Dave Langelsman, Spectrum. Just a great talk, both to Dr. Palamo and Dr. Chanayan. Thank you. Terrific, strong evidence for the use of this technology. Beaumont has a really strong, great program, and it's mature and it's integrating CTA FFR into the flow of the emergency room for chest pain evaluation. Are you able to, a lot of people on the line probably either don't have that sort of maturity there or would like to have it. Can you maybe at a high level explain the process of the flow of care within the ER and how do patients get to that CT FFR in an efficient manner?
Yeah, so the first step is actually to establish a CT program, and that requires a very collaborative kind of multidisciplinary approach between the ER physicians, the cardiologists, and the nuances of the ER. If, for instance, if there is a chest pain unit, if there is an observation unit, and what the practice is at the level of the institution. And so this requires a lot of this collaboration, and then establishing CT first as a modality that can be used, and then defining what risk patients you are going to include in that algorithm. So the workflow and algorithm where you say these, if you have, for instance, a heart score or whatever score the institution uses, this is the appropriate patient. And then there has to be a pool of readers for a CT and who are available, and because these studies need to be interpreted in a timely manner. So there is that, and then the whole technologist aspect where you have to decide where these patients are going to get the beta blockers, how will they be transported, who is going to take care of those kinds of issues, and then the interpretation. And then when you bring in the FFRCT, then also it is, who's going to be responsible for this test when the results come back, and then how do we actually convey these results to the referring physician? Mm-hmm. So it is, the workflow is complicated, but it's done. A lot of centers are adopting it, so it is doable.
With outstanding results, thank you. We just a quick note, just if you do have questions, please put them into the question and answer section. So we'll move on to the next portion here with the two individuals who've been previously introduced, Dr. Akesh Rusia and Dr. Rob Safian, for our next phase.
Thank you. Hello, everyone. Just going to discuss a case. A 69-year-old patient was referred for a CTA due to progressive angina. Just of note, she had metastatic lung cancer, and her oncologist noted that her expected survival was about 2 years. I'm going to discuss the CT first, and then we can kind of discuss the referral decision to refer for a catheterization. So on the left panel, this one right here, this is the CTA of the RCA, and you can see there's two lesions. Approximately, there's a 25 to 50% mostly calcified lesion, and then more distally, there's a 50 to 70% mixed plaque lesion. The next picture is the left coronary, which was also significantly diseased. There's a 50 to 70% mixed plaque disease in the left main, as well as in the proximal LAD. The study, due to the intermediate results, were sent for FFR, and there was a lot of data here to go over. So, on the right side, starting on the right side, the FFR proximally was not significant. It was 0.89. However, that distal lesion led to a flow drop, which led to an FFR value of 0.65, which was significant. On the left side, there was a significant left main lesion, which led to low FFR values in both the proximal and proximal LAD as well as the proximal circumflex, 0.76, 0.75. Additionally, there were several other lesions. Notably, the proximal LAD had a significant lesion, which led to another flow drop, as you can see in the distal LAD as well as the diagonal branch. There also was another significant lesion in the obtuse marginal, which was likely a small vessel. At that point, a discussion was had with a cardiothoracic surgeon who noted she wasn't a candidate due to her for bypass due to her metastatic disease. So at that point, she was referred for catheterization. She was loaded with aspirin and ticagrelor, and the plan was to first intervene on the right side, and then subsequently, once there was flow down the right side there, they would next turn their attention to the left coronary, perhaps in a staged fashion. I want to give it up to Dr. Safian to discuss the interventional portion of this.
Great. Thank you very much, Akash, for that presentation and for not deleting my slides. And I wanted to thank the organizers for inviting me to participate. So Akash did a nice job of showing you the clinical information and the CT and FFR data sets. And what I wanted to do for the rest of the discussion is talk to you a little bit about the heart flow planning software, which is useful for planning revascularization, either with surgery or with stenting. We did a review on this that was published in CCI a couple of years ago, and basically the principle is fairly straightforward. So the first step in terms of the planning is these white circles identify lesions that are greater than 30%, and you can interrogate one or more lesions as you see fit. So the first thing is to identify the lesion that you want to assess, and then look at the FFRCT, proximal and distal to that lesion. The second step is to remodel the lumen with the planner, and you can see that schematically here. You can adjust the modeling of the lumen to be longer or shorter, just depending on how you want to do it. Those are the different scenarios that you can look at. And when you're happy that you've selected the right spot and the right length, you can remodel the lumen completely. That's sort of a virtual stenting, and then the program will give you the lesion length. The nice thing about this is once the lesion has been completely remodeled and you have the FFRCT result, proximal and distal, you can assess the FFRCT after your remodeling. So your corrected FFRCT, if you will. And then if you want to do additional things to that lesion, like make the stent longer or shorter, look at the impact on bifurcation, or just turn to another lesion, you can do that quite readily. So this is an example, not the patient that we looked at, but this is just sort of a general example of how you can apply this. So if you look here, just focus on the LAD for the time being, you can see there's a lesion here greater than 30%, and then there's a lesion here greater than 30%. So from a clinical perspective, a revascularization standpoint, what you want to know is, do I need to treat this lesion, that lesion, or both lesions in order to be able to normalize the FFR in the distal LAD. And before I show you how that's done, I just want to point out that you'll see up here the lesion length, and then you'll see a notation, open the lumen, which is the virtual remodeling, or you can revert the lumen, which negates the remodeling. So the idea is you treat this lesion, you assess it, you can look at both lesions, and then if you say, well, what does it look like if I just want to look at the more distal, you can revert this one back to where it was and then just assess this. So there are lots of different scenarios that you can look at. You also get these warning signs on the program so that if you're crossing the bifurcation, it doesn't mean anything except to warn you that you're crossing a bifurcation. It doesn't mean that you have to do anything with the bifurcation, but it's just a warning sign. So we're going to look at 3 scenarios. We're going to look at fixing the proximal lesion first, fixing both lesions second, and then reverting the proximal lesion back to where it was originally and just assess the distal lesion, and then make a determination of whether we have to do 1 or 2 lesions in sequence. So I'm just going to start this, and so here you see the FFR values come up, and you can see now that we're going to open the lumen. This is the length here that shows up. It's about 15 millimeters. And now we're going to say, okay, we're going to open this lesion, and we do that. And with both lesions open, now the FFR is 0.82 across both. We're going to revert this lumen back to where it was and just assess this, and it doesn't correct the distal FFR. So go back to both lesions. And the best distal FFR result that you get is 0.82 with revascularization of both the proximal and the mid lesions. So that can be accomplished in about 35 or 40 seconds. So it's very easy to use. You can do as many scenarios as you want. You can make the stent shorter or longer, but it's a very, very nice way of determining how to assess a single lesion, multiple lesions, or diffuse disease. So in the particular patient that Akash presented, this is what the model looks like in the heart flow planner. So you can see circles are identified in multiple places here. Here's the FFR, and you can see that before you've done anything, the FFR in the circumflex and in the LAD are both abnormal due to the LAD stenosis. You can see that there's an additional drop in the LAD farther down, as Akash showed in the original model. So this suggests a severe left main and LAD stenosis. So that's your first step. The second step, we're going to do the remodeling. So the first thing that we're going to do, or the first thing that I did, was put in a stent from the left main into the proximal LAD. The planner indicated that the stent length was 12 millimeters, and we're going to look at the FFR values after we place the stent in the left main and LAD. So you can see that just by treating the left main into the proximal LAD, the FFR in the proximal LAD and the proximal circumflex are normalized. But when you did that, it didn't do anything to correct the value in the mid and distal LAD, which is shown here. So now we take a second scenario. Here's the lesion in the mid LAD. We're going to put the planner across that. That distance is 21 millimeters. So 21 plus 12 is 33 millimeters total from the left main into the LAD. In this particular strategy, we looked at what this would look like if we were proximal to the diagonal branch or distal to the diagonal branch. And you can look at both. And step 3 is you do the complete remodeling, and then you assess the values of the FFRCT once you've remodeled whatever segments you're interested in looking at. So in this case, here you can see the FFRCT is 0.88 after revascularizing up to the diagonal branch, and 0.90 if you do it distal to the diagonal branch, so not much of a difference. When you look at the final model, stent left main across the proximal into the mid LAD, that normalizes the FFR in the LAD and in the circumflex as well. So the insights that we got from this particular planning model are that you have to stent from the left main to the mid LAD. A single 32 or 33 millimeter stent from the left main to the LAD will normalize the FFR in the LAD and in the circumflex without doing anything additionally. in the circumflex. There's no need to stent across the origin of the first diagonal branch. That's sort of optional. And in this case, the pre-procedure planning probably saved her life. And I'll show you what happened subsequently. So the patient went to the cath lab. As Akash said, the initial plan was to revascularize the right coronary artery. Here you see the picture of the groin, not a good candidate for any kind of support. Proximal disease in the right. Here's where the FFR was, definitely abnormal. Here you can see the left main and LAD. This is the AP caudal projection. Here you can see the AP cranial projection. Pretty much this was suggested by the CT. Unfortunately, after doing the left coronary angiogram, the patient decompensated. So even though the plan was to revascularize the right coronary first, the patient said, "I don't feel so good. My chest really hurts and I feel like I'm going to pass out." And the ECG at that point on the monitor showed about 5 millimeters of global ST depression. Her blood pressure was in the 80s. And when the operator, I wasn't the operator, although I read the CT, but the operator called me down to the cath lab. The left main was occluded. And so I said to the operator, just get a guide and a wire down there and put in a 3.5 by 32 millimeter stent. Don't screw around, don't put a balloon pump in, don't do CPS, don't do anything else. Just get a wire down there and stent it from the left main into the LAD. So that was what was done. A 3, 5, and a 4 millimeter balloon were used to optimize the result in the LAD and in the left main using intravascular ultrasound. And then once the procedure was done, you can see the result here in the caudal projection and the cranial projection, and the patient was immediately better. This, took between 5 and 10 minutes to get this done and to get the patient completely revascularized. So this worked out very well, and that's why I say having the information from the planner, which I knew, and when I went down to the cath lab to help, I just said, based on the planner, this is what you have to do, and that's what they did, and everything was everything resolved very, very quickly. So we've kind of made a shift, or we're in the process of making a shift from using CT and FFRCT for purely diagnostic purposes. And Mike Akinvitha showed you this. You can get the coronary anatomy, you can get plaque characterization. We didn't talk about this part, but you can also use the CT and FFRCT to calculate syntax score. You can calculate a syntax 2 score, and with the FFR values, you can get a functional syntax score as well, just like you do with invasive techniques. So with the addition of the FFR, you have information about lesion-specific ischemia, and now with the planner, not only do you have the diagnostic abilities, but you can also use the heart flow planner for planning revascularization strategies, either with percutaneous techniques or with surgical techniques. So I'll stop there. I'm happy to entertain any questions. Thank you very much for your participation.
Hey, Rob, it's Ryan Mader. Excellent talk. Very provocative and a really beautiful case and a nice save, I think, that you showed. Two questions, really. One, to clarify, the prediction of the stent length that the software spits out, I got the impression that that was really focused on restoration of the lumen, so that you normalize the FFR, which of course is going to be what improves the patient's symptoms. But it seems like that CT is particularly well suited also to ensure that you don't have geographic miss, which of course doesn't have anything to do with restoration of the lumen, but ensuring that you don't land the edge of your stent in a large plaque burden lesion. Are you using the CT images before a PCI to also ensure the absence of geographic miss and thereby, reduce your likelihood of stent thrombosis or restenosis?
Yeah, it's a really good point. So one thing that I should have clarified is that with the heart flow planner, you have to use the CT images in combination with the FFR model. you can't just rely, or you shouldn't just rely on the FFR model. And when you look at the CT, of course, you can determine, where the plaque begins, where it ends. You can determine where there's mild plaque that you don't have to worry about. And so when you go to the planner and you have those CT images in your mind, that's why I said you can adjust the length of the segment that you want. The length is not determined by the software. The length is operator determined. So now, one of the nice things about the heart flow model is it frequently picks up the shoulders of the lesion, not just the most critical spot. So often from the heart flow planner, you get the same length that you would get from the CT. And in addition, you get the same length that you would use in the cath lab. I mean, it turns out to be very, very close, within millimeters. The one thing that heart flow has to work on, and I know they're working on this now, is with the planner to be able to get the diameter of the vessel, because that is not quite ready for prime time. So when I do these things, I use the CT measurements to get the reference diameter proximal and distal to the lesion, and then I sort of interpolate that to determine the stent sizing. But the CT measurements are almost exactly the same as intravascular ultrasound measurements. They're very, very close. So it's a really good question.
Yeah, and that's really interesting to hear. And do you find yourself with the CT actually using less intracoronary imaging pre-PCI and perhaps only using it, kind of post-PCI, which of course will save you lots of time and perhaps increase throughput in the cath lab?
Yeah, I mean, when you use the CT and the FFRCT, it does save time. It saves contrast. If a vessel is known to have minimal disease by CT, you don't need to do an invasive angiogram of that vessel. You can just focus on the target. So we do that readily. If you have the CT measurements and you take the time to do those measurements, then you don't need intravascular ultrasound unless there's some other nuance you're looking at perhaps after the procedure, or you want to assess the stent dimensions after you've put it in, something funny like that. But otherwise, you don't need invasive FFR or IFR unless there's something ambiguous or you're not quite sure. But doing all of this with the CT data set and with the heart flow data set really allows you to do a lot of things that you can just base your decision making with the CT and the FFRCT.
That's great. A question from the audience. What would be the role for coronary CT in an asymptomatic diabetic patient? Does CTA work for a screening program?
So Mike or Kavitha, you want to tackle that one? I think everybody needs a cath, so.
Kavitha, why don't you share your insight on that?
Yeah. So, theoretically, it makes sense, right? I mean, why not use CT as a screening tool in everybody, and not just diabetics, and maybe intermediate risk patients and higher. However, this is not recommended by any society, ACC, AHA, SECT, all societies basically discourage the use or routine use of CT. And that's because of radiation and technique. Even though, we see in the literature that radiation dose has come down significantly with the newer scanners, that's not the reality for the real world. Scanners where the radiation dose continues to be high. And so it's not recommended. And also, I think there is this whole big nuanced discussion on whether patients are truly asymptomatic or they just have a low exercise tolerance, or they are not being challenged enough with regard to workload. So there is that. But, this is what is there in the literature at the moment.
Do you mind if I just make a quick comment? So I agree with everything that Kavitha said. I guess, one of the questions is if you're inclined to do a non-invasive test on an asymptomatic patient who has multiple risk factors or diabetes or what have you, then I think the question is, what is the test you're going to use? If the choice is doing an MPI or a stress echo versus a CT, then I think the CT, you know, hands down gives you much more information, and I think it's much more valuable. If the, you know, the question is, do you do nothing or you know, medical therapy, but you don't do any diagnostic testing versus doing a CT, then I think that's a tougher question to answer. But I think if you're going to make a choice that you're going to do a test, but you're going to choose between an MPI or a CT, I think the CT is just hands down much better.
Another question that came up, there's been good evidence tonight for the strong gatekeeper role for CTA, and is stress testing dead? That was what came up. Is there a role for it? Is it just for patients who can't have a CTA, or are there some other places perhaps that we can still find a place to salvage imaging in those arenas?
Yeah, it's a good question, David. I may take the initial stab at it and then maybe hear from Kavitha. I think, you know, the goal of tonight and the goal of fellowship training, the goal of education, we talk to our fellows, is really to understand the overall strengths and weaknesses of every imaging modality. And so our fellows and our trainees need to understand when and how to use a CT angiogram, what the strengths are and the weaknesses, when and how to use a stress echo versus an MPI versus a PET versus a cardiac MRI, and when to go to the cath lab. And so I do think they all really nicely complement one another. But I think what we're trying to say here is that CT should be a part of the picture. It really should be. And you should look at your patients and understand when and who you should perform a coronary CT angiogram. And absolutely, stress testing is not dead and will never be dead. There's a long list of patients that stress testing and physiology and functional significance is extremely important. The list that we mentioned early on, of course, the contraindications, but as well as patients with established disease, patients you need to look at aerobic performance, patients you want to look at blood pressure and heart rate and EKG changes. You know, there's a long list of things that stress testing is useful for. So I always am a bit hesitant when we give a talk like this that should not be the takeaway, that it's dead. It's the takeaway should be, you should be sort of agnostic and really understand what test is right to use for which patient and not be biased to one technique versus another based upon, you know, considerations that maybe are not clinically accurate.
I just want to say that I think it's really important for, you know, especially fellows in training to move away and never actually step into that idea of modality-specific thinking and move to patient-specific, patient-centered thinking. Because in any given patient, we may do a CT and a stress test and an MRI and a cath. So it's not a modality-specific thing. You know, it's really what the patient needs, and it's disease-specific and so on.
Another question that came up was about not just the effectiveness, but FFR, but the cost effectiveness. There is a significant cost for some patients. Data to support this modality, Mike?
You know, Kavitha, I may have you take a stab at that first, or Rob, because you both looked at it. I'm happy to. There is a nice paper that's just published in JAMA in December that I'd be happy to share with you. But Kavitha, do you have any general considerations regarding that? You've looked at that with our data.
Yeah, when I've looked at our Beaumont data, actually, when we look at the overall resource utilization, then including the cost of the CT FFR, then the the resource utilization dollars are actually the same, whether you do a CT or whether you do a CT with FFR. Because when you have just a CT, then all the other tests that may come after, such as an MPI and a cath and the hospitalization, it kind of adds up and sometimes exceeds doing CT with CT FFR.
I guess I would add one comment to that, and I'll just share a screen for a second, is that this is a nice paper that was just published in JAMA last month, and it looked at cost considerations, and it was really interesting, published in JAMA Open Network, and their conclusion at the bottom is the results of this study suggest that anatomic strategies such as CT may present a more favorable initial diagnostic strategy, and it supports the recent ESC guidelines. And they really looked at, this was a cost analysis of the PROMISE trial, and when you look at the cost data of functional testing versus CT and FFRCT, there was really quite provocative data. So I'd encourage the attendees to take a look at that paper in December. So with that, David, I think I think we've kind of run the course here, and I just wanted to thank everybody, in particular, thank the Grand Rapids team at Spectrum Health for moderating this session, and all of our fellows. You know, this is really a cornerstone of what we'd like to accomplish here with this webinar series, is to have fellows in each training institution highlighted and involved in the education throughout these sessions. Also want to thank the planning committee, in particular, you know, David Wones is the president of the Michigan ACC, and Alice Betts. This was their idea to begin this virtual webinar series. Alice is the engine for all of this, as you all know. And so I just want to thank David and the entire planning committee team. Chadi Alrays is on the line, and he's just an amazing social media and digital moderator. And so thank him for all of his help here tonight. Want to thank HeartFlow. You know, HeartFlow, in addition to bringing the technology to each of your hospitals, the engineers and scientists and staff there at HeartFlow are really an invaluable resource to the development of a CT-FFR program. And so we want to thank them. And finally, I want to give a plug for the next session in February, sponsored by the Detroit Medical Center on the management of multivessel coronary artery disease. Dr. Chadi Alrays and the rest of his colleagues will be presenting that. So with that, unless Alice or David or Michael, if you have any other comments, I'd maybe like to bring this session to a close. So thank you all for attending tonight, and please go to the Michigan ACC website to sign up for these monthly seminars, and have a good evening. Thanks.